Okay, so welcome everyone. It's great to have you back, and delighted to kick off day 3 of this event, where we have a lot of really good material prepped for you that's going to really get going this morning and continue through the day. Mohammed and I talked quite a bit about trying to optimize some of the aspects of the schedule today to deliver value. And this afternoon, we'll have some time set aside, good for project work. We might have a breakout session for those who are interested specifically in discussing issues with interfacing the sort of data we've been talking about with simulation models. And we have a lot of experience in that in our lab. And whilst our analysis on and discussion of advanced simulation will talk about that a bit, we may go into more detail in a separate breakout session as well. So yesterday, we spent much of the day covering the basics of data sources, and these data sources were extremely varied in character, but broadly they had to do with background collected data that sensed context, context from the physical environment, context from the electronic environment through the electronic footprint sensors like screen time, app use, and capturing aspects of browsing activity. Okay, and by and large, these sensors lend context to understand the surrounding situation when people answer questions via surveys or volunteer information via surveys, say via button pushes. They also can be used for triggering in some cases. So things like beacons and things like geofencing can be used to trigger the occurrence of surveys. So those data sources play a strong role. In the afternoon, we proceeded to discuss some issues having to do with participant recruitment and human ethics. I had cut down a broader set of slides to try to focus on a subset of materials, but some really good questions came up that I wanted to help address this morning related to this, to supplement those materials in ways that there have been interest expressed about. So we talked yesterday about sensitive studies with those with limited agency, like minors, cognitively challenged individuals who are in certainly medically vulnerable situations, those with HIV/AIDS, those struggling with mental health challenges, suicidal ideation, etc. I should have noted some of the roles. There's some unique characteristics also with inpatient populations, and in needing to be cautious in the context of working with patients who are inpatients, say in a hospital or in a mental health facility. Or individuals who are frequent outpatients. And we have a fair degree of experience with this across many studies. There's some special needs and special opportunities that come in there. One has to be very careful from an ethics perspective to make sure the clinician-patient relationship isn't seen as being in any way compromised or limited by this relationship. So it's very important for ethics boards often that the offer to participate in a study by a clinician be offered without any degree of concern by the patient that this might that them declining participation might compromise the relationship between them and their clinician. This is a frequent thing for RCTs, for randomized controlled trials, and other needs as well, but it comes up in this area. We have found that the clinical environment and the inpatient environment, more particularly, can offer a great location for when you're working with wearables, and where you can help patients set up with wearables, for example, because of the added level of contact. It can provide some extra support for things like recharging phones and helping to maintain them. And often there's a very ready network that can be used for getting the data very quickly back to the Ethica servers. Mohammed, I don't think, talked about it, although he showed the screen in Ethica. But Ethica does have an option for rapid upload of data. So within the Ethica app, in the settings area, so if you go to kind of the menu in the upper left and you do settings, there's a set of options with respect to upload. For example, to limit uploading to when you're charging the phone, to upload via Wi-Fi only. That's something that can be set for a study as a whole or on a per phone basis. And then rapid upload option. And in a clinical setting, often we have that network to allow us to rapidly upload data. I'm going to be talking, per Brianna's question yesterday, about provision of phones by studies. I will say in an inpatient setting or a setting with frequent outpatient contact, it's very easy to provide phones and indeed retrieve phones that are provided. And the fact that the participants are local allows you to work with them more closely and often deal with any issues that come up more readily. So this is a special type of study that does come into it raises both ethics issues and planning issues that need to be taken into account. Yesterday, one thing I didn't talk about, but it's worth mentioning, is the phenomena of allowing participants, for the sake of raising comfort of ethics boards and to empower participants. For some studies, we have offered the option of retrospective or retroactive participant opt out of a study. And by that I mean that they can opt out in a way that all their data from earlier is deleted. So not only can they pause the data collection going forward, but they can say, I want out of previous times. And Mohammed had put into place in an earlier version of Ethica a participant dashboard by which, for some studies, participants would be able to observe their data and be able to request elision of that data or deleting of that data. So, for example, if they had neglected to pause the data collection yesterday in the context of behavior they'd rather not have had recorded on the phone, they could go back and retrospectively delete data. That functionality is being overhauled right now, but the plan is to fold that into some of the capacity for participants to interface with the system through the web that Mohammed will be talking about later this morning. In Ethica's future evolution, there's going to be a huge option for participants to interact via the web with Ethica studies, and this will be one part of it. Brianna, yeah.
So this is something, maybe a bit of a nitpicky question, but I've been working on this with our ethics application.
Totally.
And I'm just curious how that works in terms of, like, the data is deleted then from the phone, from the servers, and from all of the server backups. Like, has the data really disappeared?
Okay, this is a great question, and yes, it's highly appropriate. So certainly, that is the goal that I think we would expect, that the data would be deleted from databases, but also from backups. But that does require an additional level of back and forth. So I want to ask Mohammed what the plans are for that in the short term, so we can comment.
So the data will be deleted from everywhere that we store the data, and from the backups as well. So the data will not be stored anywhere. One point to consider, like, it goes really into technical details here though. Some of these services that store the data, like for example, like Kibana that we presented yesterday, because they wanted to really improve the performance of the system, they implemented an approach called add-only data storage. What it means is that when you can only add the data, you can't remove it. You can remove it, but what they do is that they just add another record on top of this, saying that this record is deleted, which basically is not the same as deletion. This is exactly how internally the systems work. When you say go somewhere and say delete this data, they don't delete it internally, they just mark it as deleted. So when you query it, they say, okay, this shouldn't count in the results because it's deleted. Then every few months, a process happens like an overnight called compaction that goes through it, like when the load on the system is lower, and actually deletes everything from the disk. So now, the reason it's important is that if when we do call the delete on all these systems, but they actually don't delete it right away. Now, unless that we actually call a compaction procedure after every delete, which in that case the system performance would be a lot slower than what it is. But when the delete is called, maybe shortly after, or anything between 1 to 3 months after, the data completely will be erased from the disk as well. And as soon as this command is called, the data will not be accessible anymore.
So I appreciate Mohammed's fulsome answer there. As Mohammed notes, we're dealing with technologies upon which different systems are built, including Ethica. And a very common example of that is with disks, where there's disk storage, and when you delete a file, it makes it incomparably more effort intensive to go back and find any evidence of it. But for at least a certain amount of time, often after you delete it, there is some residual data. So if someone were to capture the disk and look, in principle, they might be able to track down some hints of what was there before. And indeed, in law enforcement, forensic investigations, that goes on, that people nominally delete a file and someone grabs it. When you're dealing with encryption and encrypted data stores, it's even more involved, because if someone got the disk, they couldn't make sense of what was there. But from what I'm hearing from Mohammed, at a broad level, data is systematically deleted from all places, but there may be a delay in realizing that deletion.
A good example of that is that when you delete a file from your computer, it's actually not deleted. If it was completely deleted, it would be impossible to restore it. But you know that there are a lot of services out there that restore the content of the deleted disk, right? The reason is that when you delete a file, just the name that points to that file is deleted, which basically tells the system that this space is free to use in the future, but the content that was there previously is still there. So you can give it to a professional, and they go through that and they try to figure out what was there before. The same technology applies to databases as well. When you delete something, it doesn't immediately delete it. But this is like very much into technical details of how exactly delete happens. But in terms of like us deleting the data from the backups and from the database, yes, that is it. And one thing I have to mention is that we specify in our privacy policy that we delete all the instances that we have, but you can go and export the data and then participants should contact the research staff separately in case that they have exported data elsewhere. So those instances also get removed.
Yeah, thanks very much. That's really helpful. Did that address your question, sir? And per comments earlier, having that sustained conversation with Mohammed or yourself later today, if this is something you want to know more about, that could be a subject for further discussion there. Okay, I did want to just address one or two other questions that had come up yesterday. One was the issue of I say here incentives. The word incentives is a poor choice for my coverage here. It's I'm using it in a very colloquial sense, but it's a sense to which human ethics boards are actually rather sensitive, saying this is an incentive versus this is a compensation for someone's time or a thank you, an expression of thanks on the part of the researcher. Incentives are a term that is fighting words for some ethics boards, I found, and therefore it's a poor choice of mine to list this there. But I'm using it in a colloquial sense to ask what draws someone to participate in this study, and are there things that we can do to further motivate them to participate? And there are cases of studies we've run where participants have been interested in engaging with their own data. In other studies, we've provided non-monetary motivations, things like a card to go to a local coffee shop, or phone cards that will cover data charges. We've also provided raffles in some of the earlier studies in which Mohammed was involved. I think one of Ethica's earliest studies, or one of Ethica's predecessors' earliest studies, we raffled off an iPod, I think, which was a prized item at that time, as I recall. In other cases, participants are drawn by the ability to share on community sites, to contribute to their community development and to contribute in a positive way to their community. So I had mentioned the very forward-leading visionary study led by Tarun Kadapalli called the SMART study, which really leverages that to great effect within this province. There are quite a few studies where we have compensated people's time and contributions in a way that's based on their degree of involvement or participation. So we provide them a certain amount, say on a per study basis that per survey basis that they've answered, but chosen those to be such that they're never inimical to health. For example, if there's a study which is looking at cigarette and e-cigarette use, we don't want to incentivize someone to report more cigarette use, for example. And the idea is to design systems which provide compensation for involvement, say for answering surveys that are asked of them, popped up and asked of them, while avoiding adversely affecting their health choices. And this has been highly successful. I believe a study that Mohammed has been involved with, which is going to be rolled out at a multi-thousand person level, used sort of schemes very much based on this, and achieved very high levels of involvement. study Cheryl delivered, I believe it also had measures of completeness of response that were rewarded, and a number of other of our studies have as well. It requires a research assistant to do a computation or some code to do a compensation to reward participants. And in some cases, I think that's an automatic method. Mohammed, for that study, was that automatic? It would compute the compensation due participants?
The one that involved time use?
Yes.
Yes.
Yes, yes. And in other cases, with lower SES populations, we have provided smartphones, sometimes with accompanying data plans, as a compensatory arrangement or as incentives. The risk here is coercion. On the part of the ethics board, they may say, look, if you're offering a homeless person a smartphone, how are they going to say no? Or you're giving them a data or a plan, a phone plan, can they realistically turn that down? And if so, have you not morally compelled that participant to participate despite nominally being able to decline? And so within the low SES context, there's some concerns involving coercion that are non-trivial about wanting to avoid putting someone in a position that they, because of life circumstances, they can't reasonably turn down. We have had a lot of experience with data plans and offering data plans. My overall comment here is, if you can do it in a uniform way across all phones, pair them with data plans and give them out, that's okay. But often we find certain participants want to use their own phone and they're with this carrier, these other participants are with that cellular carrier, and providing a data plan that works for a given participant may be quite tricky because you're dealing with 10 different carriers with different data plans. Some have unlimited, some have 2 GB per month, and it can get into a confusing situation because of all the different combinatorial possibilities with their carriers and data plans, etc. So one has to be careful promising data plans, and if you're going to do so, try to do so in a way that you know exactly the carrier and the data plan that's going to be used for all participants. Otherwise, it can get challenging. For low SES participants, often there may be limited Wi-Fi access, but Ethica runs for days offline and longer, probably weeks. It could run offline, and so if you're not in need of data streaming in every few hours or once a day, if you're willing to live with a couple days between getting data from participants, Wi-Fi may still be a good option because a lot of individuals who do have smartphones seek out Wi-Fi. They'll go to a public library or they'll go to a public building where there is Wi-Fi. So the point is, even in low SES populations, our observation is that Wi-Fi contact for someone with a smartphone typically occurs every few days, and if you can live with that, that's good. If every few days is too little and you want to start reminding people after just a day of not hearing from them, that can be more of a problem, and you should think about data plans. Has special considerations for low SES population. It used to be that Ethica, there were a lot of concerns about Ethica imposing overage charges on participants. The idea is that if participants had a really lean data plan, that Ethica might lead to charges being socked to them, and that might disincentivize people. That's retreated as an issue because, number one, Ethica does allow both participants and study designers to specify this option of not allowing anything but Wi-Fi access, of mandating it's only uploaded with Wi-Fi. So that's one thing. A second thing is data plans have expanded in their coverage. But a third thing is these days, the availability of streaming services, the use of video by those on smartphones is so ubiquitous. Whether it's Hulu or YouTube or FaceTime, or all these different services that people are routinely using, the amount of data Ethica collects is pretty small peanuts compared to that. And so it's literally not an exaggeration that on a Saturday morning, a teenager will probably use far more bandwidth than Ethica will across an entire month for most studies, despite the fact that Ethica is collecting big data from an epidemiological standpoint. So these issues have tended to retreat some. Brianna asked yesterday about participant-owned smartphones versus study-owned smartphones. And this used to be our bread and butter type of issue, because we have run dozens of studies with study-owned smartphones. We've also run many dozens of studies with participant-owned smartphones. We still do provide study smartphones for certain studies, particularly those involving lower SES participants, those involving inpatient populations, where it's a very controlled environment, like a mental health facility, regional psychiatric center, etc. Now, there's some real trade-offs here between these. Most studies that we run these days tend to be largely participant-owned, and most of the time entirely participant-owned smartphones. Why? People have a natural incentive to retain them. They know the phone, they're comfortable with it, and it's woven into their daily life. It's a phone that often they feel good about. The challenge with this for low SES populations is sometimes you have phones that are economy models or older models that are low on space, somewhat low on performance, and they have a screen size which is smaller. And that can be a downside. I say switching phones is an issue here. It's not an issue for Ethica as long as they install the app right now on the new phone. Particularly, it will be less and less of an issue with the web-based survey, because that can, even if they switch phones and don't install the app on the new phone, they can still be answering surveys via browser, even without the new app. But if they switch phones, there may be several days where their data is not coming in, and you might want to be aware of it. Ethica is a very nice way of keeping track of multiple devices for a given person, so it's not a problem there. But sometimes you lose them for a couple days because they just forget to install the app. That's retreating as an issue because of this web-based survey and the availability of SMS-based and email-based reminders, which is something Mohammed will be. He's shown some parts of that now with the email-based reminders. SMS-based reminders are going to be an important reminder mechanism, which will help remind people to answer surveys even if they're on a new phone, and even if they do so with browser. So switching phones is retreated as an issue. And then participant-owned smartphones, to the degree you're dealing with data plans, it gets complicated because they have different plans associated with their phone. This again is less of an issue now because of the level of data collected by Ethica is small compared to streaming entertainment. Okay, and streaming communication. So phones, study-provided phones. We do a lot. We have done dozens of studies like this. You can select an effective model. Sometimes this, we used to select effective models, particularly according to price point. You know, a model that was cheap, but offered, you know, a suitable set of functionality. Over time, that has, as the number of options, particularly in the Android side, has risen. What we find ourselves looking at is often now more features like biometric security. So if the ethics board is extra comfortable, or your sureness of a phone being in possession of a participant is extra sure by having it fingerprint protected, for example. You may want a model that allows that. Or maybe you want phones which have humidity, temperature, and pressure sensors because you're doing work with nosocomial infection spread in a facility and you want to know something about the humidity and the temperature of the environments to which participants are exposed. You can, if you're in an inpatient facility, you may want to hand out phones that have these extra sensors. Here you can choose telecommunications provider. You can ensure you're starting with adequate space. The cons here are pretty notable, and it's sobering. 4 years ago, in some work with Harvard, I remember vividly, this is work with lower SES populations, you know, being surprised that some of the participants were turning down our phones. They said, you know, we don't want your stinking Android phone. You know, I'm an iPhone user. And that's a reality, that among low SES populations, there are preferences. But more than that, some of those participants said, my phone is better than your phone. I'm not going to take your phone, you know. If you're standardizing around a phone, that can be challenging. It can be costly. Phones are not as expensive as they used to be, but they're not cheap, particularly, you know, more expensive models. This last one, risk of non-return, it's a major issue for certain subpopulations. We've had a number of phones go missing. There's some really funny stories associated with this. One phone ended up being taken back to Persia and disappearing somewhere in that country. Another phone was taken by a participant, and we could actually see the participant driving around Saskatoon on the ring road and so on. And so we knew where it was, but we didn't go after it. It was quite interesting. Other phones have been stolen, have been damaged, have been lost, have been impounded by the police. So that case of the vehicle which had narcotics in it, and where the participant fled the police who seized the vehicle. And the phone was then, for a number of days, sending out signal in a impounded car lot, I think, in the police impounded car lot, and we never got it back. What we have found is for very vulnerable populations, those, for example, struggling with mental health and particularly addictions issues, those intravenous drug use populations, those working with intoxication problems, non-return of phone is a serious issue. We did find to reach out to them, we needed to provide them a phone. We did not receive, many of those phones we did not receive back. And Tina can tell you a little bit more about that if you're interested. But we had real challenges with that population as far as keeping phones. The spirit was willing, but the environment was so adverse, they lost them. Okay? Yes, Brianna.
Curious about the same issue with wearables, if you're providing wearables
Yes.
in to a community sample, maybe not a high risk or highly vulnerable sample, but thinking about some of the same issues around non-return or
Yeah. Yeah.
familiarity. I don't know if you have experience with that.
Yeah, we do. So we do hand out wearables within certain groups. We've done work with that in a number of studies, and we haven't had as big an issue with that. Maybe it's because the wearables we've dealt with were predominantly less intrusive, things like wristbands and so on. They were pretty easy to maintain, keep on a person. There we haven't had big challenges.
Do you ever let them keep the wristband at the end of the study?
Yeah, okay, very good question. That is part of the incentives for a lot of these studies is you get to keep the phone or the wristband. And if you consider the depreciation rate for phone, for a longer study, that's a very reasonable thing. You know, if the study is a year or two in duration and they get to keep the phone after it, often it's simultaneously a very attractive incentive, and it's and it means less disruption for them when they end the study, and it's more incentive for them to maintain it. So you're absolutely right. Like with the wristbands, that's something which can be a draw to maintain it, keep it properly maintained, etc. What we have had is, I'm not sure how much it's operated for wristbands. I've wondered about it. Has had issues of phones which were provided to family members, unbeknownst to us. Someone else took the phone and used it as if it were their own, even though nominally it was associated with, a person of opposite or different gender and so on. It was in fact taken by a family member. And same thing I would imagine for wristbands sometimes. There may be a risk that the wristband is being used by someone else. I know my colleagues who run large accelerometer studies have told me stories about, people who, teenagers are particularly challenging because they often are mischievous in their intentions, and, they've done things like taken actigraph accelerometers and put them on their dog and had the dog run around a field and experience huge acceleration and given the impression that the participant is engaged in massive physical activity when really it's canine in origin. I imagine that for wristbands or for wearables, that it could be that they'd be of interest more to certain family members sometimes than the participant, and mischief like that could be done. But we haven't had problems with wristbands when we've handed them out. Those studies are small, and by small n I mean the count of studies where we've done that is small enough that it's more anecdotal on my part. We haven't had the problem we have with phones. So that's what I'd say. I'd say it's less of an issue than with phones. Phones are also very desirable. You think about you think about a very vulnerable population, like individuals struggling with drug addiction on the street. A phone is very attractive target for theft because it can be picked up and used by someone for immediate goals, and it has a certain it has the ability to be used in all sorts of ways very flexibly, and sometimes it's an advantage that someone else's phone, then since you won't get blamed if there's drug deals made with it or something like that. Whereas wristbands tend not to be as much of an issue. They're more special purpose function devices. And so, and same thing with a lot of wearables. It might offer limited. It's hard to imagine someone else having a hankering for, you know, a Hexo shirt or something, or really, really coveting that, you know, that chest strap that measures heart rate variability. I guess it can occur, but, you know, those things I think are rare. So study-provided phones, I will say this. Study-provided phones, 10 years from now, 5 years from now, I expect that we will still be doing some study provision of wearables and smartphones or their evolved descendants, which will probably, you know, will be very interesting devices. The point is, I don't see this going away. What I see it is getting more specialized. When do we do this? It's for certain populations, certain very defined circumstances. When we started this business, we were handing out devices. That was the standard way you did it. To deliver a study, you would hand out devices. It went part and parcel of it. And Mohammed engaged in a lot of that. Yeah, there's some great stories there. Mohammed triggered a bomb alert on campus one time, but and it was because of devices that we handed out and placed in locations. In any case, there's some great stories. I don't think this is going away. It's getting more specialized. It's getting more particular. And I think with wearables, some of the studies that we work with send out wearables via a mail and have them returned via mail. That's a very viable strategy, I think. It does have to be policed, or that's not the right word. It has to be supported by reminders and so on. But you know, circulating wearables is something that can really be cost effective. You rotate them among participants, and in general, sorry, I should have mentioned another scheme that recurs in a lot of our studies. You have a broader study, and then you have a subset of that study, and potentially a rotating subset, which undergoes especially focused data collection. Cheryl's study with foodborne illness, for example, actually had a phenomenon that we see in a lot of studies, which is a defined period of time, like a week, where you say, you know, win one for the Gipper. During this week, we're going to be bombarding you with messages. Please know that it's only going to last a week. Try to keep up with it. And after the week, you know, you'll have done your duty, or you'll have completed your big task here, and it won't happen again. A lot of studies, that's a really good way to set expectations, retain people despite a lot of pressure. They know it's going to be over in a few more days, and they know from the start that that they're going to be asked to help out a lot during some particular time periods. In other studies, we will do that with wearables, so we'll ask them to carry a wearable for a subset of time. Or you have, of the whole study, a subset of people who are particularly willing to volunteer their time and effort carrying wearables, and it's a sub-cohort that you use to figure out, you know, some of the day-to-day patterns that are lost for the broader set of cohort, but you capture via the wearables, and then you try to generalize to the broader study. Often harder to do, but with the rotation to different sub-cohorts, it's you know, can be very effective. So I would say this whole picture of like providing phones to a subset of people or providing wearables to a subset of people has various combinations that can be very effective, including temporarily limited rotations. Okay. So I noted some considerations for inpatient populations. I'm conscious of the time. We have some really exciting material coming up, but I want to talk very briefly about certain items that are of great significance for most studies. So what I'm going to do is stop this recording so we can place this in a separate video, and this is going to be some brief comments on budgets and timeline. Okay. And some comments also on the a frequent question that we've gotten in some context, to wit,